Hi, it's Dr. Centeno, and coming to you a little bit off the usual time. Normally it's 1 o'clock Mountain, which is 3 o'clock Eastern and noon Pacific. But we're in the holiday weekend. I know we've got a lot of people traveling, and I've got some things scheduled today as well, some off time. So I wanted to get on Facebook Live and only spend about 30 minutes today. I don't have the full hour, but I wanted to go through some new developments with regard to getting procedure notes after a PICL procedure. And just go through that. We discussed lots of things here, talk about new research, new ligaments, new treatments, and then sometimes just some housekeeping. And that's what this is today. So as usual, I'll give a short presentation and then open the floor to questions, whether it's about this or anything else. So let me go ahead first and share my screen here. Looks like that worked, and we'll get into our short presentation for today, then answer some questions. So this is a new system for procedure notes after a PICL procedure. And as you know, PICL procedure is the one where we come from the front. We use a 3D printed mouthpiece to try to help the ligaments that hold the head on. And this is for craniocervical instability patients. And we often get immediate requests for procedure notes after a PICL or other procedure. And patients are pretty impatient about this. I want this yesterday. Now, I don't know of another clinic that provides immediate notes after the patient is seen. And as you know, if that clinic is in a large hospital system, it could take months going through multiple different departments to get records sent to you. So it's been an interesting back and forth, right? As a small clinic, patients often send repeated emails when they don't get their procedure note immediately. Again, in hospital settings, that generally never, ever happens. And given that we had assigned one person to provide these notes, a sister in the procedure, scribe, which means take other notes, and handle all the patient communications, receiving the notes was often delayed, and patients were often getting frustrated by all of this. So to break the logjam and make sure patients know exactly what was injected, I've created a form that will be handed to the patient or their family member during discharge from the clinic that'll go through exactly what was injected during that procedure. And this is what the clinic note will look like. It basically talks about, for instance, facet joints injected, next list of items there, internal upper cervical ligaments injected, etc. And it'll give a short description of each of these so that the patient can understand. And it allows my staff to just check off the various things that got done. It also has whether that structure was successfully injected, attempted but abandoned to protect patient safety, not attempted to protect patient safety, etc. So the patient knows what we were able to accomplish, what exactly got injected. They can walk out with that information. And then the actual procedure note is merely going to be a formality. It's going to say the same exact thing. So there won't be this long-term waiting. Now, I have detected that a few patients are really impatient about getting these notes because they want to try to submit these to their health insurance carrier. And I would say, please do not do that. And that goes back to a story when I first started doing orthobiologic procedures almost 20 years ago. And this was a patient I had come in from Boston. We were doing a culture expanded mesenchymal stem cell injection in this patient's knee. He wanted his notes. He wanted his super bill. We provided both. He then proceeded to commit basically insurance fraud. He looked up some codes that his nurse girlfriend had told him would get reimbursed without question. They submitted these codes. One of them was a bone marrow transplant code, and they got it paid. And then we went through this 1 or 2 year investigation phase because the insurance company eventually figured out that they had paid it in error. And it was a real insane scenario that really started with the patient not understanding that, or not accepting, he understood, not accepting that the procedure wasn't going to get reimbursed by his health insurance company. So while we do have coverage for this procedure through the Regenexx corporate program, and that's 1,000 US employers and expanding, so you should check on that, in which case we will get you these notes for that purpose. If you're trying to submit these procedure notes to Blue Cross Blue Shield, Cigna, Aetna, it's not going to get reimbursed. And if they reimburse it, it'll be reimbursed in error. And you'll owe that money back at some point to the health insurer. So please do not submit this to a health insurer on the idea that you're going to get reimbursed somehow magically, because it is not reimbursable through those types of large health insurers. I don't know why that's not advancing here. Here we go. So instead, our notes are for our internal records of what was done, medical legal documentation, and reimbursement through workers' comp or auto insurance or similar cases where there is reimbursement, but they are not. And again, I'll stress this again, for reimbursement through United Healthcare, Blue Cross Blue Shield, Cigna, Aetna, or any of those. They can also be for reimbursement through the Regenexx corporate program, but that's specific to employers. So again, please do not submit these notes or ask for them to submit to those large health insurers. So we should be instituting the system this or next week. I'm hoping that it will really break the logjam and the patient will leave with exactly what was done or what was not done and have some idea of what occurred. And again, to go over it a third time, the purpose of our notes is not to submit them to Aetna, Cigna, Blue Cross Blue Shield, United, etc. Insert the name of whatever health insurance company you would like. So please don't use them for that purpose. You're just not going to get reimbursed. And if you do, it's going to be an error and you'll owe that money back to your health insurer eventually. Okay, let's take some questions. This will be a quick one, just 30 minutes today. This will be a 4th of July weekend edition, if you will. Let me get out of that. And then we'll see if we have any questions. Don't see any questions right now. I think obviously being the holiday weekend, we don't have a lot going on. But if you have any questions, let me give you a couple more minutes here. Here's one coming in. Stefan. Hello, Dr. Centeno. I will be with you soon. I have a long flight ahead of me. Do you have any tips for me or anything I should be aware of during a long flight? My ears were also affected. Not so much during a long flight. The best advice I could give you would be to get up and walk as much as possible. We know that there is a deep venous thrombosis risk in long flights. Now, that's really, really rare, but that happens because patients aren't able to get up and walk around. So I'd recommend getting up, walking around once an hour or so. Obviously, at the same time, you want to balance that against sleep. So if you're coming from Europe to this direction, my recommendation usually to patients is to take a short nap during that direction of flight, but don't sleep so long that you can't get to sleep that first night, because that's a critical part. Outside of that, hydrate well, and looking forward to seeing you. Kirsten, having PICL in 2 weeks. My iron is at 7.2. Having infusion next week, but likely won't be over 30 as you recommend. I think you're talking about a hematocrit rather than an iron. So let me know, because hematocrit would be the density or of your blood, or really how much is in the tank. So their hemoglobin of 10 or hematocrit of 30 would be approaching our minimums for doing the procedure or canceling it, not iron. So let me know if we're talking about a hematocrit here. Yes, Ulysses, this is early today. It's holiday weekend, just had stuff going on. So I'm trying real hard to see if I can get out there today with something to answer questions, and just trying to make sure that everyone gets their questions answered as usual. Any other questions I can answer? So what we're talking about today is PICL procedure notes. We're going to be changing that system so patients leave with something in their hand, which is a form filled out by staff, which says exactly what was injected. And that way, we won't have the person providing those notes constantly getting bombarded by emails. After that, the notes may take 4 to 8 weeks to get done. We won't be submitting them to anyone who wants to try to get reimbursement from their private healthcare insurance company, because there is no reimbursement for this procedure. So those notes are just going to be provided to those who want them for their internal records, which we're happy to provide, but again, in that 4 to 8 week time frame, or someone who might be able to get reimbursement through an eligible program, either through the Regenexx corporate program or through health, or through auto insurance or workers' comp insurance. Jingnesh, can the PICL be done only on one side if there's a unilateral injury? It could be. Generally, there's no way to know if there's a unilateral injury, meaning that we have certain things we can look at that would indicate that there's a problem, but there's probably also a problem to a certain degree on the other side. So as a result, we tend to do it bilaterally, just because there's probably some issue on the other side. It may be subclinical. So that's generally how we go, but happy to discuss it for sure. So Kirsten, I think you mean 36%. Usually hematocrit is expressed as a percentage, at least here in the US. So 36% is within our range. What we'll probably have to do is just to make sure we limit how much we take to protect you, but that's within the range of what can be done. Lissy, can you make a video regarding type of needle to use for cervical spine, especially in the upper area? Sure, that's an interesting one for sure. I think that the idea of needle gauge size is important to understand, meaning we tend to see more advanced physicians use smaller gauge needles because they can. And I think we tend to see physicians that are less skilled tend to use thicker needles. Obviously, the thicker the needle, the more likely it is to do damage if it hits something it's not supposed to, which is why we always try to go with the thinnest needle possible. So that's an interesting one, Ulysses. Thank you for the recommendation. I'm always looking for new topics. If you guys can suggest new topics, I would love to hear them because I'm always interested to see what you want to hear. Sometimes, obviously I'm sitting here saying, God, what can I do today? So that's an interesting one. Thank you for recommending that. Any other questions I can answer on this wonderful 4th of July weekend? It's hot here. I know it's hot in the other parts of the country. It's probably not nearly as hot here as it is in other parts of the country right now. So we're doing this one a little early today so we can get out and enjoy before it gets too hot out there. Any other questions I can answer? So again, we've got a new system that you saw me lecture on, which is to try to get information to the patient immediately about what was injected. Jingesh, does auto insurance reimburse for a PICL? I can only go over what would happen here in the United States. So this is specific in the United States. In general, auto and workers' comp tends to be more likely to reimburse for orthobiologic care. So the general answer is probably yes. Whether it gets directly reimbursed through a MedPay or a PIP, personal injury protection, or eventually reimbursed as part of a case, the answer is likely yes. Now, compare and contrast that to through group health insurance, Blue Cross Blue Shield, United, Aetna, Cigna. People are often like, well, I got great insurance. It seems to reimburse everything. It's not going to reimburse this. So that's an incredibly important thing to understand. My CFUF counts, not TNC, are not high enough to meet my treatment needs, even with expansion. Do you think trying allogeneic cells should be justifiable? Do you have an opinion on ITRT in Spain, which uses both autologous and allogeneic expanded bone marrow-derived MSCs? Well, Brian, a lot would depend on what it is you're trying to get treated. So again, one of the things you have to be careful of is if we're talking about a spine application, Europe, Central America, South America, Mexico, the approach to the spine is extremely simplistic. And usually those sites don't have the providers with expertise that can get done or get it done on the placement side, regardless of what is injected. So I need to know more about which application you're trying to get treated, because that may be a mismatch there. If your CFUF counts, meaning your cells won't culture expand, then we get into why. That's an incredibly important thing to understand. And then allogeneic cells in general, the biggest problem is they're taken out by the host's immune system through the killer T apparatus. So bottom line is we're starting to better understand that the purpose of allogeneic cells seems to be to prompt some sort of healing response, but eventually they're taken out, unlike autologous cells. One of the reasons why many of the allogeneic cell therapy FDA approval trials have failed. We didn't understand this all that well when they were promoted 10 years ago, 15 years ago, when those companies started to enter those pipelines, but we understand it better now. So the biggest problem with allogeneic cells is that they need to be typed, but that's not practical from a financial standpoint. Hence, we're seeing these clinical trials fail. So I'm not quite sure I'd allow myself to be injected with allogeneic cells at this point until we figure that one out. Ulysses, can the IJV be blocked on one side than the other in the spine? Yeah, it's usually more blocked on one side than the other, and that's usually due to that C1, C2 rotation. But again, be very, very careful with this concept because we have a lot of people walking around out there. So I'm going to go this afternoon to an arts festival, just walk around, look at paintings. And if we take 100 of those people walking around at the arts festival who are about my age, and we do imaging, and none of them have any symptoms of IJV compression, anywhere between 1 in 3 to 1 in 5 of those people will have from moderate to severe IJV compression and no symptoms. So be very, very cautious, as I always say, about this concept that because you've got IJV compression on an image, it explains your symptoms. It may, or it may absolutely be a total red herring that has nothing to do with anything. Gamers Lounge, I had the question which I've been thinking of for a while. Did you ever have patients who were told they have lower lordosis or minor disc bulges and it turned out to be CCI? Oh, sure. Yeah, we've had a lot of misdiagnoses. That's, as many in the CCI community can tell you and attest to, misdiagnosis is super duper common. So these poor patients often tell them they're a little bit like a pinball in a pinball machine, right? They go from specialist to specialist to specialist to specialist to specialist to specialist. No one seems to know what the heck is going on. And then that causes them a great deal of stress, expense, etc. So yes, it's pretty common. Gamers, and is POTS common with cervical instability? What is the success rate with PICL? Any patients who have found tremendous relief or full recovery? Yeah, POTS is very, very common. I think we've talked about that here a number of different times. Success rate for PICL is about 7 out of 10 or 70%. Success rates tend to be higher with more functional patients and lower with the most disabled patients. Ulysses, is it good to mix lidocaine with prolotherapy or bone marrow on the spine? No, that would be a bad idea. The biggest problem with local anesthetics and cells like mesenchymal stem cells is that they're toxic to those cells. The least toxic one, and the one that should be used universally at this point, is ropivacaine. That is a labor and delivery anesthetic that's more expensive. It's harder to get since it's mostly used in labor and delivery. But in research that we published, research that others have published, ropivacaine is the least toxic to cells. So if you're doing any prolotherapy or use of local anesthetic around cells, it should be low to mid dose ropivacaine and not lidocaine, which is more toxic, and certainly not bupivacaine, which is highly toxic. Jingish, did it something inject BMC for post, or maybe do you inject BMC for posterior injections during PICL? Only be a PICL for PRP for posteriors. No, we tend to use the bone marrow concentrate to inject posteriorly when we're doing PICL. The only caveat to that might be injecting the facet joints. And that's because most people can't tolerate bone marrow and facet joints. They tend to do much, much better when we inject PRP into those facets. Eric, can loss of cervical curve cause symptoms? Regular neurologists seem to think it means nothing, say evidence that it does not matter. No, I think your neurologist is wrong there, Era. We've got some good research that's now been published by I'm blanking on their name. The guys at idealspine.com. Blanking on their last name. But anyway, they have published some great research showing it is associated with symptoms and that restoring the curve reduces those symptoms. That's also now been recognized in the neurosurgical community, where there's a big push to try to get people to fuse with a curve. So I think your neurologist is a little bit out of date with regard to understanding the literature in this area. Eugenics, mood advanced by Sherry Kopp. Is there a particular type of CCI you have identified that has better results than others? Not really at this point. I think C2-3 instability inflection is one of those ones that's easy to fix and will often be fixed by routine prolotherapy. So if we had to pick one to have, that would be the one, right? Because just routine posterior prolotherapy can usually get it done. So maybe that's a better way for me to phrase the answer, is if I had to pick one that you would have, that would be the one to have. Ulysses, how many X-ray machines do you have in your clinic? We have 3 C-arm fluoroscopes. No, more than that. 4, sorry. So we have 2 that live in one room. That's the PICL room. We've got 2 other procedure suites that each have a fluoroscopy machine. And then I lost track and count of the number of ultrasound machines, maybe almost a dozen ultrasound machines. Gamers, thank you. I have another query. What are your thoughts on transcutaneous vagus nerve stimulation, feeling the vagus nerve? Heard from previous clips that vagus nerve damage is possible from, not quite sure what maybe long COVID or something. I think it's certainly worth a shot. We've been using some vagus nerve stimulators. We've used them in 2 patients. I haven't really seen much, or 3 patients. I haven't seen much of great responses from those patients, but I still like the idea. Ulysses, I heard loss of lordosis over cervical spine can also cause IGV compression too. Well, it can certainly move the upper cervical spine closer to the internal jugular vein. So while not a cause, it might be an aggravating factor. Era, when my vertebra shifts, I get extreme itching. Yeah, Era, not quite sure what that mechanism is. other than to say that it could be related to the vagus nerve, meaning that we know that the vagus nerve is involved in healing and getting us into that parasympathetic state where things are calmed down. So the sympathetic state can cause itching. So it's possible that that's one mechanism. Gamers, would stimulation help counter the effects somewhat? I haven't seen it work yet, but I love the idea. Ulysses, can C3 to C7 rotate a lot, or just C1 and C2? No, they can all rotate, although C1, C2, since it's responsible for 50% of your head rotation, is going to be the one that would rotate the most because it's got so much rotational natural ability built in. Stefan, is there an option in Colorado to undergo A or NUCO treatment? There is, Stefan. Just contact Carla and she can get you set up here. Regenix, made advanced by DB. Do you notice any connection between skeletal type like petiteness, broadly built, and proneness to CCI? I don't, other than to say tall women in general seem to be more prone to neck injury. Isabella, how toxic, dangerous to use lidocaine in combination with prolotherapy in the occipital region along the base of the skull is supposed to use to calm the nerves? Well, yeah, any local anesthetic used in that area that could inadvertently be injected into the vertebral artery or injected intradural is a bad idea. That's one of the reasons why, if we're doing any deep injections in that area, we will use fluoroscopy with contrast and digital subtraction angiography. So if you're doing superficial injections in that area, you need to use ultrasound. If you're going any depth, you need to use fluoroscopy with contrast and digital subtraction angiography at a minimum. And then I'm just going to take a few more questions because remember, this is a 30-minute edition today, but I appreciate all the great questions. Era, my vertebra moves like extreme skin. I think I got you there already. John, do you recommend a regular chiropractor or a chiropractor of biophysics for bulge disc and help restore a curve in the neck? Yeah, I think an idealspine.com listed chiropractor, one who has been trained in curve restoration. Era, my C1 rotates and falls to the side, pulling my head to the left. Are there specific ligaments involved? Well, if it's pulling it sideways to the left, then that's more alar ligament. If it goes anterior or posterior, that could be lots of different ligaments. So for instance, if the atlas slips forward, then slipping forward can be due to some of these posterior ligaments back here. If it slips backwards, then that can be due to some of the deep anterior ligaments, for example. Ulysses, do men and women have the same anatomy for the cervical spine? They do, but they're built differently with regard to the amount of muscle per vertebra. So I think that's why we tend to see tall women being more likely to get injuries in things like car crashes because there's less muscles per unit volume of vertebra. I would love to know how to pronounce that name. So I'm just going to skip the name pronunciation. I apologize. Just touching the point from Ulysses, can loss of lordosis cause dysautonomia? Like symptoms, I've seen an article, I think it mentions absent cervical. It's a good question. I have yet to see an article that talks about that. So maybe if you can leave a link to that, I will look at that. Isabella, I believe it caused a bunch of symptoms, specifically my tinnitus has gotten really loud. I got to go back to what Isabella said before. Yeah, so Isabella, if someone injected you with local anesthetic deep in the upper cervical spine and they didn't have X-ray guidance with fluoroscopy and digital subtraction angiography, in my opinion, that's below the standard of care. So if there was an inadvertent injection of that stuff into the brain, it would cause brain damage, for example. So that's obviously a bad day for everyone. Okay, guys, listen, it's 11 a.m., so I've been at this for 30 minutes. I know you guys are just getting going and cranking up the questions, which I really appreciate it, but this is sort of an abbreviated July 4th weekend version, so I really appreciate you taking the time to watch. And I want to make sure everyone knows about the brand new thing we're doing, trying to make sure that everyone gets the information they need about their PICL procedure. Stefan, just throwing idea, would the use of anabolics help people with CCI to build neck muscles, goal of getting more stabilization from them? Probably not, because it wouldn't impact the deep muscle atrophy that we see. Okay, Era, thanks so much. Thanks, guys, for watching today. You all have a wonderful 4th of July. Thank you.